Welcome back, my dear students. Myself, Professor Dr. Deshpande, would like to welcome you back in this interesting webinar, recorded webinar on electrocardiogram. ECG reading made easy by Professor Dr. R. Deshpande. I am MD in Ayurvedic medicine and MD in Ayurvedic physiology, two post-graduation degrees. And I have the 35 experience of teaching and consultation in Ayurveda and integrated medicine. My WhatsApp number is 9226810630. My dear students, my dear doctors, I'm always telling you that now this ECG record, to take the ECG and to read the ECG, to interpret the ECG, is now under the what I can say arena of the general medical practice. Say 20 years back, 25 years back, when we talk about ECG, every family physician just refer the patient to the hospital, and then in the hospitals, cardiologist or the specialist or every physician, they do this type of the ECG and then the interpretation. But now, on and off, when the patient complains of, oh, I'm having the chest pain, oh, I'm having a little bit burning sensation in my chest. So it's a duty of a doctor, family physician, general practitioner, to take the ECG and to see whether there is any cardiac element for the chest pain, cardiac element below the complaint of gas. So this is very important because stress is day by day increasing. Fast food plus fast life is equal to fast death. Forget about the death, but the people are suffering from the heart attacks even at the age of 30 years. So mind well, this particular fast lifestyle, our bad habits of eating, wrong quality lifestyle, and a lot of stress here and there are making ourselves prone to the cardiac problems. In the part one, when we met in the first time, I have discussed the different cardiac elements, and then I have given the explanation of the basics of the ECG, electrocardiogram. It is also called as EKG. You understand? And this is the only webinar I can say that you can get on Professor Dr. Deshpande's mobile app, which is also called as Ayurveda Academy. Myself has a very fantastic YouTube channel where I am sharing my knowledge and experience free of cost. In this particular app, I am also providing you my experience and sharing my PPTs, videos, and audios. But here you will get a very interesting recorded all the things, so you can enjoy the thing at all the time, anywhere, anytime, and whatsoever time you want. So let us start to discuss the further about electrocardiogram. So this is a part 2 session of our discussion. So let us start about part 2. But before that, let me revise what we have learned in the morning session, in the previous session. So I have given you the important formula, how you can determine the pulse rate by ECG. I'm not saying you cannot do the pulse. You can do the pulse physically also by palpation. But I'm saying you can record or you can note the pulse rate by just looking the different leads. Especially I have mentioned that the lead 2 is very, very important. In the 12 lead ECG, there is a long lead. So this PQRST complex has been repeated, say 3, 4, 5 times. Then it is called as a long lead. My dear friends, BPL company, there are a lot of companies who are providing you. I am also giving you the link sometimes on the YouTube, Amazon, where you can purchase this ECG portable machine. It's very cheap nowadays. So even in during the visiting hours or during the emergency visits, you can take this ECG machine with you and just rule out the cardiac element. So this is about the pulse heart rate. I'm sorry, here you can see the pulse rate is equal to heart rate. So that is 300 divided by big square in the RR waves. Okay. So another point I have discussed in the first session, that is left axis deviation. The mnemonics was left leaves, okay, and right axis deviation, right reaches, okay. So for the determination of the axis deviation, because this is the normal axis, I have already mentioned that when it is pulled on the left side, the current, electrical circuit is pulled on the left side, that is left axis deviation, and when it is pulled on the right side, that is the right axis deviation, okay. But for this, I have made this webinar Very, very, very easy. So the common student, common doctor can easily understand, and they can use all these mnemonics, all these formulas in their general medical practice. Very easy to remember. So you have to check only first and third leads and see the R wave. When in the first lead R wave is up and in the third lead R wave is down, that is leaves. That left axis deviation leaves that R waves are leaving each other. But in another case, they are towards each other. That means in the first lead, the R wave is a downward deflection, and in the third lead, that I have the upward deflection. Now you cannot have to worry about. You can see all these videos many, many times as much as you want in the 1 month period. Okay, and very cheap. I have kept the price very cheap because otherwise you go to the any hospitals or any what you can say the regular money making business that only 1 day seminar and 3,000 rupees, 1,000 rupees fee for ECG determination, not necessary with Dr. Deshpande. Okay. Next, here you can see the revision. Here I have also shown that particular lead in the first station. So this is R wave, this is P, Q, R. This is R, this is S, this is T. So this R and this R. Can you see? So 1, 2, 3, 4, 5, 6, and 7. Do you understand? 7 big squares. Always note the dot squares and the big squares. So 300 divided by 7, it is coming round about 42.85, that is less than 60. So when pulse rate is below 60, it is called as a bradycardia. So this is the part of revision. Okay. Now, in the second session, I'm going to discuss very interesting things like LVH, left ventricular hypertrophy. Left ventricle is the most important chamber of the heart because by pumping this chamber, the blood is circulated from head to toe. You understand? So left ventricle is very important. Of course, right ventricle is also important because it is making the heart and lung circulation for the purification of the blood, heart and lung circulation. But left ventricle is the most important part, and that's why I have mentioned in the first session itself that when you do 2D echo, remember this word, it is like a what you can say the USG of abdomen. You know that similarly USG of the heart is called as 2D echo, echo, ECHO. And this particular, when you read that, only make attention on the word EF. Don't forget, write it down. EF, ejection fraction. And it should be more than 50. Okay. But here, actually, when there is a failure of left ventricle, then ejection fraction gradually comes down. And that is called as a weak heart, WEAK. Okay. We will see right ventricular hypertrophy, how you can identify with the ECG. Right atrial hypertrophy, which is also called as P-pulmonale, because the pathology in pulmonale means lungs. So this is a typical, always atriums are related with the P wave. Atrium always related with the P wave. And QRS complex, ventricular depolarization, contraction, and T wave, ventricular repolarization, relaxation, contraction, relaxation, contraction, relaxation, cardiac muscles. So this is right atrial hypertrophy, which is also called as P, because problem is the P wave, pulmonale. Because of the lung problem, the heart is also becoming the problematic. LAH, left atrial hypertrophy, which is called as a P mitrale, mitral valve. You know, from the left atrium and left ventricle, there is a valve which is called as a mitral valve. So when there is a left atrial hypertrophy, the problem is always in the mitral valve, mitral stenosis, mitral regurgitation. These two words you should remember. Then MI, myocardial infarction, that is heart attack. There are two types of the less blood supply. When there is a blood supply problem, there are two types. One is less blood supply, that is called as ischemia. IschEMI. Ischemia means less blood supply to the cardiac muscles. Who are providing the blood to the heart? Coronary arteries. Right coronary artery, left coronary artery, and there are two branches. So this myocardial infarction is absolutely stoppage of blood. That is infarct. So this is the difference in ischemia and infarction. Ischemia is the less blood supply, which can give the problem like, yes, angina pectoris. Angina and pectoris. Angina, the Latin word meaning is I cry, C-R-Y. The cardiac muscles are crying, oh, I'm having the less blood supply, less blood supply. That is angina pectoris. This both angina pectoris and myocardial infarction are called as a RHD. RHD, ischemic heart disease. Okay. Myocardial infarction, even within half an hour, within 1 hour, within 2 hours, you will get some changes in the ECG. Changes are different in the first 4 hours, in first 24 hours. After a week, there are different changes in the ECG. You can diagnose this is a recent heart attack. This is the case of chronic heart attack. This you had heart attack say 3 years back. You can diagnose by ECG. Okay, and the stress test is very specific for angina pectoris, this particular problem. Chest pain, chest discomfort, retrosternal discomfort, pain, radiating pain towards the left shoulder, left hand, radiating pain to the left jaw, radiating pain to the back after exertion. So less blood supply. Blood supply becomes less when there is an overactivity. When the patient is sitting, no problem. When his patient is sleeping, no problem. But when he starts climbing upstairs, when he starts climbing up hills, then there is a problem. Exertional dyspnea. Dyspnea means breathlessness. And for that matter, to diagnose the angina pectoris, resting ECG is not useful. Remember, write down this word. You cannot diagnose angina pectoris only taking resting ECG. Then what has to be done? The patient has to do some exercise, but under control, under the supervision of expert, under the supervision of computer. Okay. So whenever the doctor, whenever the technician, or whenever the expert, he feels, the changes are coming on the monitor, on the computer, he says the patient, stop, 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 slow down, slow down, slow down and stop. This is called as a treadmill test, stress test. So stress test is done only to diagnose angina pectoris. Is it clear? Resting ECG is useless to diagnose angina pectoris. Okay, next. Now, normal pattern and amplitude of QRS complex in the chest leads. In V1, small P wave, but deep S wave. Actually, this is shown only, this is the S wave. Try to understand. This is again P, okay? Then V2, V3, V4, V5, V6, when proceeds towards the V6, height of the R wave increases. Height of the R wave. Here it is very, very less, but gradually it is going increasing. In V1, you cannot see the much more about the R wave, but in the V6, you will get a tall R wave. And S wave progressively decreases. This is the difference. Okay. So here no R wave. Here little bit R wave, but S wave is still there. R wave increasing, S wave becoming short, R wave increasing, S wave becoming short, R wave increasing, S wave becoming short. This is the usual physiological normal pattern of R wave and S wave. That means QRS complex when you will see V1 to V6 leads, especially in the lead number 2. When you see the total strip of the ECG, total plate of the ECG, you have to see firstly the second lead, and then you will get this normal pattern. Actually, V1 is very small R wave which has not shown over here. I will show you the actual graph afterwards. Okay, but here you can see R wave is gradually increasing from V0 to much taller in the V6, and S wave is gradually decreasing. Here you can see S wave very little, but R wave is tall. Okay. Now, here I do not go into detailed molecular physiology or giving you the biophysics explanation. No, I'm giving you very shortcuts for the general medical practice. Okay. So let us see what is happening with this LVH. What is happening? In LVH, the most important diagnosis pattern remains the same, but amplitude increases. These are the simple slogans I have prepared, and you have to just diagnose by these slogans. Left ventricular hypertrophy. When it can happen? I have already mentioned in the first session. Anybody is remembering? When the patient is having hypertension, and that too chronic hypertension, 5-year hypertension, 10-year hypertension, and a little bit uncontrolled hypertension. Diastolic BP is always above 100, always around 110. Then that is problematic. Okay, so that can give the pressure on the ventricle, and ventricle has to push the blood more forcefully because there is obstruction. Hypertension is nothing but depends on two things: cardiac output and peripheral resistance. Most of the time, because of the what you can say the atherosclerosis, because of the arteriosclerosis, the blood vessels are becoming rough, tough, and with all the plaques of cholesterol inside. Dyslipidemia. So always the cardiac problems more over time are associated with problem with the cholesterol metabolism, fat metabolism, lipid metabolism, same one and the same things. Cholesterol above 200 milligram percent, triglycerides above 150 milligram percent, bad cholesterol is there, LDL, VLDL, very, very bad cholesterol. And what is the good cholesterol? HDL. So always do the lipid profile test in the fasting condition of the patient when you will get this type of the LVH problem in the ECG. LVH is always related with chronic hypertension most of the time in practice. So pattern remains the same, but SV1 in the lead V1, S wave is greater than 25 mm or more than 5 big squares. This is usual schematic diagram. It's not actual ECG. I am going to show you the actual ECG afterwards. Okay. And R wave. This is S in V1 and R in V6 is also greater than. Now you have to see S wave here and R wave in the V6. Don't get confused. Because we have to, the pattern is same, but the amplitude is increasing. Okay. So more than 5 big squares. So totally what is happening? SV1, if you calculate, measure actually the squares of this S and squares of this in the V6 about R, they are more than 35 mm, that is more than 7 big squares. You have to make addition. Either you can see separately or you can make the addition. Normal QRS complex, 3 to 5 large squares. Okay. QRX is in between 1.5 to 2.5 millivolt, that is 3 to 5 large squares. Okay, do you understand? This is amplitude and the length, duration. How much is the duration of QRS complex? 0.08 seconds, that is 2 dot squares. This is for general information. The above formula is most important. How you diagnose LVH? The pattern of QRS complex remains the same, but the amplitude, heights of the S wave in V1, here, V1, here S wave, and height of the R wave in V6, they are increased. Okay. So let us move further. Here you can see now. Only you have to see V1 to V6 for LVH. Can you see R in V5 or V6 here? Can you see V6 and R wave? This is how much tall? You can see greater than 25 mm. 1, 2, 3, 4, 5, 6, 7. I have already mentioned. Similarly, S in V1. This is S wave. Can you see S in V1 or V2? Also here. Can you see S wave? How deep? Greater than 25 mm. And so R plus S. R wave plus S wave. If you calculate, that is more than 35 mm. Okay. So these are the actual electro ECG paper graph. Okay. Here you can also see that in V5 and V6, the R wave is very, very tall, greater than 25 mm. And here in V1 and V2, V6 is deeper. Okay. Next, we are going to discuss when you will get this LVH. So R in V5 and V6 is greater than 25 mm. S wave in V1 and V2 leads is greater than 25 mm. So naturally, R V5, V6, V5 or V6 plus S in V1 or V2 is greater than 35 mm. But remember, This is only not diagnostic. Young, thin people with normal heart rate may have R and S greater than normal. This is the exception. This is the, that's why we always say in our medical practice that pathological tests or any investigations or any reports that we do with the gazettes, they should be compared with the complaints. They should be correlated with the clinical examination of the patient. So if there is a very thin patient and young person, then this can happen even physiologically. Okay. If LVH look for evidence of strain, that is ST depression and T inversion should be in addition to this finding. There should be some ST depression and T inversion. Echocardiography is diagnostic to be echo for LVH. Echocardiography is diagnostic for left ventricular hypertrophy, and treatment should be given according to the cause. Treat the original cause. For example, there may be chronic hypertension, there may be aortic stenosis, there may be coarctation of aorta, then there may be hypertrophic cardiomyopathy. Okay, this is all about LVH. Now I will go further. Here we will talk about RVH, right ventricular hypertrophy. Here, prominent, the scenario is totally opposite. I have said that in physiological condition, in the V1 you will get the S wave. Am I right? And in the V6 you should get the R wave. But here the pattern is changed. Pattern is totally opposite. For example, prominent R wave in V1 lead, opposite than the normal, and deep S wave in V6. So SV1 and R to RV6, this is the becoming the normal pattern. Okay. Now RV1 in the V1 lead, when you measure the R wave, it is greater than 7 mm. That is 1 big square plus 2 dots. This formula you must remember. Okay. But it is very easy. And S in the V6, S in the V6 is greater than 7 mm. That is 1 big square plus 2 dots. Now, if you mixed two addition, RV1 plus SV6 is greater than 10 mm. That is 2 big squares. Okay. Next, we will go further. Here you can see the RVH, right axis deviation. Whenever there is a ventricle hypertrophy, the current is pulled. Current is pulled. Electrical current, heart current, cardiac current is pulled on the right axis. So right reaches. Can you see? This is the first lead and this is the third lead. And this is the R wave. This R wave is like coming over here, and this R wave imaginary, in the mind only. You feel that they both are coming together, right? Reaches, reach each other. So this is the right reaches. Then deep S wave in V5. This is opposite to normal QRS complex pattern. With S wave, P, Q, R, S, and this is T. Do you understand? So here, this is R and this is S. S wave is deep and also V5 and V6. Then there is also right bundle branch block, broad QRS complex, and M in V1 and W in V6. This we are going to discuss afterwards also, how to diagnose bundle branch block. This is the problem in the electrical current of the heart, starting from SA node, AV node, bundle office. There should be some problem. And how it is diagnosed? Broad QRS complex. Here you can see V1. Here you can see there is this Q, R, S, and this is T. This is T. But this particular area has been widened. Okay, and this pattern is called as a M pattern. Like here, you get the sign of M. So M pattern is there, and in the V6, you get the like this W pattern. So this is M pattern and this is W pattern, which is indicating right bundle branch block. Okay, next. Now we are going to see again about the RVH. I have repeatedly telling you dominant R waves in V4 to V1 to V4, right axis deviation because of the right ventricular hypertrophy, deep S wave in V5 and V6, as well as there may be right bundle branch block. Always there should be, if it is pathological, this is called as if with the strain. The cardiac muscles are under strain, and then it is indicated by ST depression and T inversion. The most common problem of right ventricular hypertrophy is pulmonary hypertension, pulmonary stenosis. So whatever the treatment, you have to treat this pulmonary hypertension and pulmonary stenosis. Automatically, this ventricular hypertrophy will be under control. Let us move further. Now, we are going to see the right atrial enlargement. Right? Atrial. Atrium is always related with P wave. Atrium is always related with the P wave. QRX, ventricle. T wave, ventricle. Okay? Right atrial enlargement, which is also called as the P-pulmonale. How it is diagnosed? Tall P wave greater than 2.5 mm. Here you can see this, although it is looking small, but it is more than 2.5 dot square, that is more than 2.5 mm. This is in the lead, this is P wave, okay? In the lead 2, also in the lead 3, and also in the lead AVF. Here all the waves, P wave, this particular P wave, first positive deflection, upward deflection is more on the height. And that is because of the problem with the lungs. Because the pressure is coming on the right atrium. Because back pressure, it is called as a back pressure. Okay. So right atrial enlargement is always called as a P-pulmonale. Next, here you can see another close-ups of that all the things. Tall P wave greater than greater than 2.5 mm, that is 2.5 dot squares. Okay. Here in the lead 3 also tall P wave is there, and in the AVF also there is a tall P wave. That is isoelectric line. This is isoelectric line, and above that there is more than 2.5 squares. This is related with the atrium. Okay. Let us move further. Now, we will talk about right atrial enlargement again with the deep sense of causes. Tall P wave that is greater than 2.5 mm, that is 2.5 dot square in the lead 2, in the lead 3, and also AVF lead. Causes: primary pulmonary hypertension, secondary pulmonary problems like chronic bronchitis or emphysema, pulmonary stenosis, and tricuspid stenosis. Because there is a valve in right atrium and right ventricle, the valve is called as a tricuspid valve. And here on the left atrium and left ventricle, the valve is bicuspid valve. That is also called the mitral valve. But when there is a tricuspid stenosis, narrowing, valves are not functioning properly, the blood is making a back pressure, and that right atrium has to push the blood more strongly to the lungs. Okay. So patients history, you can take chest X-ray, you can do to assess the cardiac dimension and the lung fields. Echocardiogram, that is 2D echo, to assess the valvular disorder. Whenever there is a mitral valve problem or tricuspid valve problem or aortic valve problem, you can diagnose very well by seeing the circulation with the 2D echo. If you can estimate the pulmonary artery pressure as well. Okay. So next we will go further to discuss about the left atrial enlargement. Now I am talking about left atrial enlargement, that is P-mitrale. Can you see P-mitrale? Their height was more in the previous case when there was a right atrial enlargement. Now here the P wave is more broad. Only simple thing, P wave more tall, P wave more broad. When more tall, that is called as a pre-pulmonale, and more wide, that is called as a P-mitrale. The problem is in the mitral valve. So this is the left atrial enlargement. P wave is wide, greater than 0.08 second or 2 dot square, and is also bifield. You can see here 2 up separation is there. That is bifield, separate bifield. Can you see here first lead P wide and 2 dot square, more broad wave is like this. Next we will go further to see another explanation, like for example P wide greater than 0.08 seconds or 2 dot square. Can you see here bifield? Then also here you can see bifield. Here also you can see it is not more clear, it is more clear over here, but it is always wide. P wave is always wide in the atrial hypertrophy. P-mitrale, left atrial enlargement, P is wide, greater than 0.08 second or 2 dot square, and also bifield. Usually results because of the mitral valve disease. Then that is why it is called as the P-mitrale, because P wave is there And mitral means the mitral valve problem is there. Left atrial can also accompany. That means left atrial enlargement is always more over time accompanied by left ventricular hypertrophy. Again, because of the back pressure. This word is very important, back pressure. Secondary to hypertension, as I have already explained, aortic valve disease and hypertrophic cardiomyopathy. As like the P-pulmonale treatment, P-mitrale does not require treatment of its own, because if you treat the mitral valve problem, automatically this enlargement will under control. Okay, so let us move further. Now, this is more important topic, which is many students and doctors are interested. Doctor, tell us how we can diagnose the heart attack, myocardial infarction. There are three cardinal signs, but clinically you know that the patient may be a little bit elderly. He may be having comorbidity like chronic hypertension. He may be the obese person. He may be having the habit of fast lifestyle, eating fast food. So all these are together, accompanying no exercise, eating a high calorie food. Then there may be atherosclerotic changes. There may be dyslipidemia, lipid profile is very bad, and the patient is come to you, this type of the patient, obese person, squeezing type of the fisting his, pinching his thumb fist as like this, oh, doctor, discomfort. Profuse sweating. I am always mentioning profuse sweating from his, all the garments will be clenched with the sweat. So much sweating is there. Sweating can happen with the two conditions in general medical practice. One is hypoglycemic coma. You must remember for the diabetic patient, his blood sugar is definitely down, or the heart attack may be there. These are the only two conditions where the patient will complain of profuse sweating, or you can see the patient is drenched with the sweat. So discomfort will be there. There may be, because in the diabetic patient, chest pain is not at all present sometimes. You may be misguided. Oh, there may be acidity problem. He has eaten something, vada pav yesterday or some curry yesterday. He may be having complaint, doctor, no, doctor, I am having constipation and lot of gases in my stomach. Mostly it is a gas pain. Don't go on these statements. For this little doubt, you first do the ECG and confirm that this is not at all related with cardiac problem. Then only you are safe. Otherwise, the first 4 hours, first 1 hour, first 2 hours are like a golden hours. In the cases of paralysis, in the cases of heart attack, in the cases of anything related with the kidney, brain, and heart. So you must send to the patient to the hospital, do first ECG at your family level or the family physician level, do in the general practice, go to the, if you are in the visit, open the ECG machine and immediately do, whenever the patient complains of chest pain, chest discomfort, profuse sweating, nausea, gas, or hyperacidity, anything, you must do the ECG and rule out the probability, because other diagnoses are called as the diagnosis of exclusion. First, you rule out this myocardial infarction. Elevation of ST segment. Can you see this is P wave? This is a hand-drawn figure. So don't go with the measurements. These are not useful for the measurements. Then this is Q wave. This is R wave. This is S. And this is again T wave. So elevation, that means this is isoelectrical line. Don't forget this line. Isoelectrical line or baseline. That ST, both are up than isoelectric line. Inverted T wave is below on the isoelectric line, and deep and wide, this is the Q wave. Usually it is not seen. But whenever there is a history of heart attack, 2 years back, 3 years, 5 years back, then predominant Q wave, you can spot diagnosis and you can ask the patient whether he has patient some heart attack previously. So this Q wave will appear more predominantly after the history of after getting heart attack. Okay. Now let us move further. Events in the chronological order. This is very important. On the first day, what will happen? ST elevated. Now, can you see S and T? This ST segment will be, what is elevated? Above the isoelectric level. This line, you have S wave is going up. Usually it should be down. Okay. Then ST elevated with upright tall T wave. Actually, this is not the proper first day I am saying. It is again a rough diagram. But T wave, but there will not be any Q wave. Tall upright T wave is not inverted in the first day. Second day, T wave will slowly become inverted. Actually, this is inverted. So this is not at all a diagram of first day. Never, never. In the first, I am here only I have shown you all the changes. together. Together. It is not related with the first day. Don't get confused. In the first day, only ST elevation. In the second day, T wave slowly inverted and ST segment still raised. Okay. And towards the end of first week, three things are there. First day, next 2 days, that is why the first 48 hours, 72 hours were very critical after the heart attack, after myocardial infarction. Towards the end of first week, ST segment returning to the isoelectric line as usual. T wave is deeply inverted. Q wave starts appearing, this Q wave, and T wave is pointed, inverted like this, pointed, inverted below the isoelectric line, and symmetrical limbs. Symmetrical limb. Okay, so this is after the 1 week. Okay, let us move further. Now, in the third week, see gradually, first day, third day, 1 week, and third week, Q wave fully developed, ST normal base, T wave now coming to the normal but flat, returning to normal after the 3 weeks I am saying. So by looking ECG also, you can diagnose how much old that particular attack is. Okay, what is the duration of the occurring the attack, and then the patient has come to your hospital or the clinic. By the end of third month, ST segment and T wave both return to normal. Only Q wave remains permanent. Of course, if the size of the infarct is too small, Q wave may also disappear. So Q wave size, how much deep, how much measurement, 2, 1, 2, 3 square, that indicates the size of the infarct. How much damage is there because of the heart attack can be understood by looking towards the depth of the Q wave. Size of the Q wave is very, very important. Okay. Now, next case is angina. I have already mentioned angina pectoris, that is the less blood supply with the coronary arteries to the cardiac muscles. So angina means I cry. That cardiac muscles are like crying. Atherosclerotic, narrowing of coronary arteries or the vessels. Patient is comfortable at rest, but anginal pain is always there after exertion. Climbing upstairs, climbing up hills. After exercise, myocardial demand of the oxygen increases, but sufficient blood flow cannot occur due to the partially occluded coronary arteries. They are blocked because of the cholesterol. Okay, anginal pain, very interesting, disappears after rest. Patient is walking, he is climbing, and when he started little bit discomfort or pain, he immediately should stop walking, stop climbing, rest, wait over there, sit down on the steps and just relax. And simultaneously, if he carries or if he knows that I have this type of the problem, he must carry sorbitrate tablet or angisate tablet, which when he takes the below the tongue, that is sublingually, immediately pain goes within 5 or 10 minutes, immediately. So after rest, the oxygen demand decreases and the patient is relieved. Acute myocardial infarction, ischemia can be seen during the stress test. So positive stress test, what is that positive stress test? ST depression after exercise. Don't get confused. In the previously, I explained that in myocardial infarction, ST elevation is there. When totally no blood supply, stoppage of blood supply, that muscle is died, cardiac muscle. Then what is happening? ST elevation in heart attack. But ST depression with the stress test, it indicates ischemia, that is angina pectoris. Okay. Now, these are the different patterns. You can see types of the ST segment depression. Horizontal or plain ST segment depression. This signifies myocardial ischemia. Again, I say repeatedly, this is isoelectrical line or the baseline. This ST segment is depressed below isoelectrical line. Okay. Then upward sloping. Can you see? Upward sloping of ST segment depression. This is another pattern. This is a variant of normal. It may be occurring normally or significant only if point depression is greater than 2 mm. This depression should be greater than 2 mm. Okay. We are seeing the different patterns of ST depression. Now, horizontality of ST segment. When ST segment, this ST segment is horizontal and isoelectric. This line is called as isoelectric line. This is early manifestation of ischemia. Early manifestation of less blood supply to the cardiac muscle. Last, downward sloping. Can you see downward sloping of ST segment? This also indicates clear-cut 100% ischemia, but it can be seen during digitalis toxicity. Tablet digitalis, tablet lanoxin, digoxin, always given to improve the muscle tone and muscle strength of the cardiac muscle. But usually it is given weekday off, Sunday off. The tablet name, another, I have given the name Sunday off tablet because it should be stopped at least once in a week. Because otherwise, if you use continuously, that can create the digitalis toxicity. This is a cumulative toxicity. Addition, cumulative toxicity. So this digitalis toxicity also has the same type of the picture of ST segment. Okay. Let us move further. Slaggy, like slaggy, concave and upward ST segment. Slaggy, looking upward, concave ST segment. This also suggests ischemia. Non-acute myocardial ischemia. Non-acute myocardial ischemia. Slight ST depression in V5 and V6, similar to the T inversion in the limb leads, or sometimes flattening of T wave in V5 and V6, just like the strain pattern of left ventricular hypertrophy. I am always explaining the word strain means typical pathological activity happening in the heart. ST segment is indicating some this type of the strain, ST depression or ST elevation or the T wave inversion, etc. This is called as a strain. Okay. Next, we will go further. Now, I am showing you the different pictures of myocardial infarction. It depends whether it is anterior infarct, anterior wall, posterior wall, septal defect. So, in anterior myocardial infarction, mostly V1, and you have to look for V1, V2, V3, V4. This is anterior wall. T inversion in V1 to V4. Here you can see P, Q, R, S, and this is T. Just look over here, T. This is also T. T inversion. Physiologically, it should be upward deflection, but this is downward deflection. This is also called as the T inversion. Can you see? This is T inversion. This is T inversion, and this is also T inversion. Okay. So, I'm sorry, this is from V1 to V4, it is clear. Now it is going up. Now it is going up. But in because V1 to V4, these leads only indicate this wall has been affected. Anterior myocardial infarction is there. Okay. Next, we will go further. Here you can see the typical V1. Here T wave. Here it is T wave. This is inverted below the isoelectric line. Next, anterior myocardial infarction, Q wave in lead V4. Q wave is seen in the V4, T inversion in V1 to V4, ECG recorded 5 days after anterior myocardial infarction. Q waves start to appear within few hours of onset and in 90% cases becomes permanent. Q wave. Diagnosis of myocardial infarction, you may get chest pain or chest discomfort, even no pain in the diabetic patients. This is called as a silent heart attack in diabetic patients. Nausea, profuse sweating is more important. Next, anterior myocardial infarction, ST elevation in V1 to V4. Can you see? ST elevation. Begin with. So naturally, this is within 24 to 72 hours. This ECG has been taken from 24 to 72 hours. ST elevation. Can you see my cursor? ST elevation. This is also ST elevation. Anterior myocardial infarction, the same case. Now, here more close-up has been taken. This is V1. Can you see? ST elevation. This is also ST elevation, and this is also ST elevation. Now I am talking about inferior inferior. Can you see inferior myocardial infarction? Then you have to look for Q wave in second, third, and AVF. Can you see? Second, we will find out 7 Q. Okay. Then also in the third, Q wave is there, and also in the AVF here you can see the Q wave. But T inversion is also there present. For example, in the lead 2. Here, can you see T inversion is there? Then also third lead, can you see? This is the T wave inversion, and in the AVF also you can see the T wave inversion. This indicates the inferior myocardial infarction. Now, this is the close-up again, Q in second lead. This is the Q wave. Then Q in the third lead. This is the Q wave. Then in AVF, this is the Q wave. T wave inversion in second, this is T wave inversion below the isoelectric line. This is in the third lead and this is in the AVF. Okay. Inferior myocardial infarction, Q in the second, third AVF. The same thing are repeatedly telling to you so that the brain will be fixed up with these ideas. Q wave inversion in second, 3 and AVF. This is 2 years previously the patient that means had attack, and this picture is we get. Inferior myocardial infarction, Q in second, third AVF, ST elevation. Can you see ST elevation in the lead second? Then third also ST elevation is there, and in the AVF there is also ST elevations. Please see this cursor, then it will be identified. Next, Q in second, this is second, third also there, and also AVF there is also. Then what is there? ST elevation. Can you see little bit up? In the third it is more clear, and in the AVF this is still more clear. Now lateral, this is the lateral wall. Lateral myocardial infarction, ST elevation in the first lead. Can you see ST elevation in the lead AVL? Can you see AVL ST elevation and V4 to V6? Can you see ST elevation above the isoelectric line? ST elevation. Hyperacute T waves in lead V4 and V5, especially V5. I will show you the close-up next slide. Can you see ST elevation everywhere? You can see very well. And there is also T waves, although it is not very clear, in the lead V4 and V5. Now, we will see lateral myocardial infarction shows the ST elevation in lead V1, AVL, and V4 to V6. Hyperacute T waves in lead V4 and V5 are in V1 and V3. ST depression in V1 and V3. Upright tall T waves in V2 and V3. Okay. Now, posterior wall myocardial infarction, ST depression will be in the V1 and V3. Can you see ST depression below the isoelectric line, V2, and this is V3. Okay. Next, again the same with the close-ups. ST depression here, V1, V2, and V3. Now, this chart is very, very important. How or where you can find out the myocardial infarction, where is the area? So anterior myocardial wall infarction is there. You will see the changes in the ECG in lead V1 to V4. When there is a lateral myocardial infarction, then lateral wall, then you can find the results, find the pathology, find the changes in lead 1, AVL, and V5 to V6. In anterolateral, the changes in the ECG will be in the lead 1, AVL, and from V1 to V6. So these things you have to remember very carefully. 100 times you write down these things, and after seeing the lots of ECG, it will be automatically comes to your mind. Of course, you have to see all the leads, but specifically, if you find anything wrong, then go retrospectively. No, I have seen the problem in V1 to V4. Then naturally, the infarction will be in the anterior wall. Although I know that the treatment does not vary too much, treatment of myocardial infarction or the heart attack doesn't change too much as per the what you can say the wall which is affected, but still as a theoretical part or as an academic interest, you must know where is the defect. Of course, the super consultant cardiologists, they are going accordingly to see what exactly happening with which wall. Anteroseptal V1 to V3, inferior wall infarct in the heart attack in the second lead pathology, third lead, and AVF. Inferolateral, there will be problem in first, second, and third lead, and AVL, AVF, and V5 to V6. So this slide number say 69 is very, very important, and you must write down all these things 100 times of your own by just remembering by heart. Okay. Next, we will go further. Here, I want to show you the stress test, ST depression, and sometimes the T inversion. Can you see ST depression over here? AVL, ST depression. Okay. Can you see the T wave inversion over here? Can you see the T wave inversion? So whenever you see ST depression and T inversion, that indicates the, of course, this has changed after the patient is walking on the treadmill. It is not at all at rest. I am repeatedly telling you, angina pectoris cannot be diagnosed by resting ECG. The ECG is taken when the patient is walking on treadmill, that is after exercise only. Okay. So can you see ST depression and T wave inversion, and sometimes there may be T wave inversion like here. Okay. Now exercise test is the most common indicator of coronary artery disease. Then J point is the junction of S wave and ST segment. Major ST depression, two dot squares after J point. T inversion may develop during the exercise, as may be because of the bundle branch block. A fall in the systolic pressure indicates severe coronary disease. Greater the depression, higher probability of coronary heart disease. So, my dear friends, I think this is the, I can start this third part maybe a little bit afterwards, but I am thankful for your patience, understanding, getting the understanding of this ECG. Take a small break, move here and there, make a little bit relaxation, and we will meet in the next our session. That is what you can say the third part of this ECG. But once again, I am telling you this facility is available because of the great app, mobile app of Professor Deshpande. That is what you can say the the best interesting app for getting the academic and these different workshops I'm going to take with these recorded videos, and you will be comfortable anytime, anywhere you can see, and as much time as you want in the whole month, and only fees are rupees 200. So I request all your friends, what you can say, convey my request to all your friends and take the advantage of this very interesting app, as well as very interesting the seminars and the webinars taken by the Professor Deshpande. Thank you very much, and all the best to you.